Hi, everyone. I am so excited to get to offer a brief introduction for Shira Shavit. As we said, Shira Shavit's a rock star, so you all know, that's why you're all here. But just to say briefly, she's a clinical professor of family and community medicine here at UCSF and the executive director and co-founder of the Transitions Clinic Network. For over a decade, through research and community engagement, Dr. Shavit has been redefining national best practices to address the health inequities experienced by communities impacted by mass incarceration. In addition to providing clinical care to communities impacted by incarceration, Dr. Shavit has led health system transformation in over 48 primary care systems in 14 states and Puerto Rico, resulting in healthcare career opportunities for hundreds of people with criminal legal involvement as community health workers. Her work in the Transitions Clinic Network has also been shown to cut healthcare and criminal legal costs and support healthy, sustained integration of individuals returning home from incarceration. In 2012, she led a Center for Medicare and Medicaid Innovation funded project across 11 sites in collaboration with City College of California. She also worked as a consultant to reform healthcare systems in the California state prisons in collaboration with the federal receivership. And she's a recipient of the Robert Wood Johnson Community Health Leader Award in 2010. Dr. Shavit graduated from Washington University in St. Louis, completed her MD at Rush University in Chicago, and completed her residency training at UC San Francisco. She's currently a California Healthcare Foundation Healthcare Leadership Fellow. So I'm so excited. I hope you all will join me in welcoming Dr. Shavit to hear about her amazing, innovative work, the way she partners with community to really enhance care for people who are system impacted. So Dr. Shavit.
Thank you so much. Thank you to Jen, for that wonderful introduction, to Bree and everyone from Arch for having me here. You all are really the rock stars. I'm looking at the names of people on this call and recognize many of your names and faces. And so I feel really humbled to be here amongst you all in the amazing work that you do. And I'm just really excited to share with you today a little bit about our work, and hopefully we'll have some time for discussion at the end. So let me share my slides here. I'm not, there we go, the most tech savvy person, but surviving Zoom. So, all right. So thank you so much for having me. As you heard, I'm Shira Shavit, and I'm a family doctor and a clinical professor. So while I partner with incredible researchers like you all, my focus is really on building systems of care for people impacted by mass incarceration, and working with researchers to and health systems to transform our practice and also our policies to support people who are coming home from incarceration. And the Transitions Clinic Network is essentially a nonprofit organization that supports health systems in transforming their practice. And as you heard, we've worked with 48 different primary care systems across the country. These are all community-based clinics, federally qualified health centers, some university-based primary care systems that have stepped forward to say, we want to change how we practice to better meet the needs of our communities who are impacted by mass incarceration. And our organization is a capacity building organization. We provide support around program implementation of an evidence-based model of care that we developed here in San Francisco, and you're going to hear all about it today. And we also partner with researchers. Emily Wong is our research director in working with researchers to better understand how mass incarceration impacts the health of our communities, particularly those returning home, and hopefully leveraging that research to change systems. And then, of course, using our collective knowledge, both from the research perspective and from the clinical perspective, to change policy within our country. So all of our programs hire community health workers with lived experience of incarceration, and you'll hear a little bit more about their role and how we develop this model of care. So we have numerous publications that have come out of this work. I'm sharing this with you just a little bit because you all are research focused. This information can be found on our website. And this is really, again, a collaboration between clinicians, health system partners, and researchers. And our most current study that we're engaged in right now, and Emily Wong is the PI of this. This is TCN Paths. This is funded by NIDA, and this is a randomized control trial looking at 6 of our sites comparing the Transitions Clinic program to usual care for people with opiate use disorder who are leaving jail. The site PIs are Carmen Albizu, Lauren Brinkley Rubenstein, Erin Fox, Diane Morris, Lisa Puglisi, and Tyler Winkleman. So many of your colleagues who I'm sure you know. And so this is kind of our most robust research that we're doing across our sites to date. I'm not going to focus on the research on it. I'm kind of going to pivot and talk more today just around kind of the bigger picture of what we're doing in supporting older adults around reentry. I'll talk a little bit about the background. I'm sure many of you are familiar, being experts in this field, and then I'll talk about our model and how we support older adults in coming home from incarceration. And then I'm hoping if we have some time at the end, collectively kind of putting our heads together to think about what are some of the research gaps potentially that exist, and hoping to hear from you all if what I share might spur some ideas or thoughts, and just thinking about, you know, ways to learn from each other and collaborate moving forward. And everyone can hear me okay? Is that, yeah, okay, good. I just had this experience where I presented at a meeting where apparently somehow they couldn't see me or hear me, but they could see me. And so I was presenting for 15 minutes before anyone, yeah, it was a little embarrassing. So please let me know if there's any problems with that. So incarcerated people are aging. I think you all are very well aware of this, and all the statistics about how sick people who are in prison are and are getting, how they have higher rates of chronic medical conditions and also contend with substance use disorders and mental illness, and that we expect to see, you know, a larger share of people within our prison settings growing older. And you know, thinking about what those health needs are for people coming home is really going to be the focus of our conversation today. The environment itself can cause or exacerbate poor health in our older populations. I think COVID is a perfect example. This is a slide I've used for years when talking about the health impacts of incarceration. I think with COVID, it just really kind of takes a whole new meaning. And in California, you know, 60% of our state prison system was a dorm setting at the start of the pandemic. And, you know, just thinking about how older prisoners or adults who are incarcerated are just so much more vulnerable in these systems, and with, you know, getting COVID. So, you know, I think it's important to recognize, as we know, these are not systems of care. They're not systems set up to support people with health needs, and in particular, older adults. And then, you know, I think that this is kind of a really kind of a bigger part I want to spend a little time kind of just talking about, which is that people, when they're incarcerated, it's very difficult for them to manage their own chronic conditions. You know, when we're in the community and we're working with our patients, we're always doing a lot of education around self-management, around behavior change related to managing chronic conditions. And yet in the incarcerated setting, people really don't have the ability to self-manage their chronic conditions. And, you know, for instance, if you have diabetes, you may not get a glucometer and be able to check your own sugars and have access to different foods to adjust what you're eating. You may not be able to get outside to exercise when you want. So the constraints of the system really make it difficult for self-management. I think the other component of this, though, is that it's not just the constraints of the system itself, but it's also sort of I think an overarching lack of support around autonomy for people incarcerated, and that really can bleed over into the health system. So when you're thinking about, you know, somebody who, you know, people are not really supported in learning how to manage their conditions. And I think I'll share with you a little bit of a story of a patient of mine that I'm taking care of currently. You know, he's a 64-year-old gentleman who has retinitis pigmentosa, so acquired blindness. So during the 35 years that he was incarcerated, he became blind. And the way they dealt with this in the prison system was they assigned him another person who was incarcerated to be his attendant and to just go with him everywhere in the system. So when he had to go to chow, this person would take him to chow. When he needed to write letters to somebody out in the community, the person would write letters for him. And so every single one of his needs was attended to by another person who was incarcerated, which was quite effective, and was really great for this individual. And then he was released from prison, and he was out on his own in the community to navigate without any support at all. So he had not learned how to use a cane. He didn't know how to cross the street. He didn't know how to use Braille. He didn't know how to use technology to navigate the community, and essentially was terrified and sat in his room at the halfway house most days because he couldn't leave the facility on his own. And I think it's really important to recognize this is obviously a really extreme example, but I think it's a really good example of how the system does not prepare people to navigate in the community. And so around their chronic conditions, they're wholly unprepared. And they're also can be very institutionalized, right? He was very dependent on that system to care for him, and not really taught self-management skills. And this can be really, obviously in this situation, very extreme, but really plays out a lot in the patients that we serve in the community, and in particular, older adults. And then these systems that people are coming from are carceral systems. They're not health systems. There's limited to no care coordination services in the community. This is a photograph from San Quentin State Prison of an elderly man who has severe COPD and is on oxygen. And he was released from San Quentin, which is in San Francisco, to Salinas, which is, I would say, probably about 3 hours south, with a very small tank of oxygen that was not full. And by the time he got to his community, his oxygen had run out, and he was forced to go to the emergency room and actually was admitted to then be able to get oxygen in the community. So this gap in service, the fact that there's very little to no care coordination services, can be pretty catastrophic for people who are coming home. So people get limited supplies of medications, but I think also when we really think about older adults, there's kind of some more profound impacts, and it really kind of comes along when we start thinking about older adults and some of their challenges. So I think the obvious we often think about are the ADLs. Can the person care for themselves, feed themselves, and dress themselves, et cetera? And some prison systems are starting to do a little bit more of that assessment, because if somebody, for instance, needs a long-term care facility, they're in a wheelchair and they can't do any of these things, then they are required to transfer that person to a skilled nursing facility. But I think what we see a lot, so we work in the ambulatory care setting, we're in the primary care clinic, so this is out in the community. So I'm not going to be really talking today about people who need that level of care. I'm talking about people in the community. And what happens is that nobody assesses the individual's IADLs. So things like, can they prepare their own food, or use public transportation, or use the telephone, or all the kind of basic things they need to do, like even handling their own medications, that's done for them. And handling, there's, finances, there's very little of that within the carceral setting. And so what we see is this very highly structured environment where all of these things are done for people. And then when they get out into the community, they really struggle with doing these things. And we see this across all ages, in particular for people who have done long-term sentences. So I care for a lot of patients who went into prison when they were 18, 19. They never were adults in the community. They never had the opportunity to do all these things for themselves, and they have to learn it. Now let's think about the older patients we care for, and that we know that many very high rates of people incarcerated have cognitive impairment, have low literacy. And so for them, doing these things is even more challenging. We think about the technology challenges people face, like even using the telephone. So what really we see a lot in the community is that people who look like they're functioning okay in prison, in this highly structured environment where they really don't need to do any of the ADLs, when they come out to the community and they don't have these supports, they really decompensate and do very poorly. And so this is a really, to me, this is something that I feel is a major issue. And you'll hear me talk more today about kind of some of the kind of changes policy-wise that are afoot that will allow us to hopefully do better care coordination for people coming out. And yet I think the question is, how do we assess these IADLs in the system, and how do we ensure that people are getting the right level of housing and supports that they need when they come home to the community. I think about, we had a patient who was about 75 and had some basic chronic medical conditions like COPD and hypertension. I think he had mild diabetes. And then he also had some mild mental health, depression, anxiety, but he was cognitively impaired. And here was somebody who looked okay, like he was kind of moving around his daily life in the prison without really a whole lot of difficulty. And one of the really interesting things too was that anytime he didn't feel well, they just told him to go to the TTA, which is essentially the emergency room or urgent care in the prison system. So he just would go there all the time for his care and got really used to just dropping in for his medical needs. And so when he got out to the community, he decompensated because he could not do any of these things on his own, handling his medications. So his mental health conditions got worse. And then he was so used to dropping into the equivalent of the emergency department that he was doing that in the community. And in about a 6-month period of time, he went to the emergency room about 150 times. And this is even while he's engaged in care. I used to be on speed dial with EMS because when they would get called over to his program, I mean, what would happen is the people in the program didn't feel like they could ignore complaints. They would call EMS. EMS would show up, and then the paramedics would call me to put me on the phone with the patient so that I could tell him, like, you're okay. You don't have to go to the emergency department. So I think it's just important to recognize that what's happening inside really shapes people's experiences and how they use care in the community, in particular with older adults, really just trying to use what they know. And so this was just another example of somebody who I think that structured system of incarceration really masked his deficits and his ability to care for himself. I mean, it's a little ironic because we don't really think of that system as being a really supportive or good system around health needs, but in some ways it really does support the functioning of older adults. So as we all know, most people return home to the community from incarceration. And then when they return, they actually get sicker. And we know that our systems are not linked. We know that people's chronic conditions can get worse. They're more likely to relapse. I'm sure you're all familiar with Emily Wong's study looking at Medicare beneficiaries that had higher rates of hospitalizations post-incarceration. So 1 in 70 individuals were hospitalized in the first 7 days post-release. And then with Ingrid Binswanger's study that people are 12 times more likely to die in the first 2 weeks post-release. So, and obviously, this is, significant for older adults who have, comorbid chronic medical conditions. So most people coming out, who are older are going to have a higher need to engage in care post-incarceration, and there's so many barriers to doing that. I think there's been some major policy shifts in our country where we've expanded Medicaid. More people have access to that. Older adults potentially could have access to Medicare. There's challenges in those benefits enrollment. We know that the documentation around SSI and SSDI for people who are disabled might be insufficient or might be fragmented. It's difficult for people to apply for those benefits or to follow the thread of an application. They may have a lack of sufficient qualifying work history to be able to get Medicare Part A or SSDI. And then they also may not be able to meet enrollment deadlines, for instance, for Medicare while they're incarcerated. I talked a little bit about the continuity of care issues, the discharge planning, the lack of health records. I mean, you have complex older adults with multiple comorbid conditions. It's really challenging to support them in the community if they don't know and they can't tell you what sort of the next steps in their treatment are or what medications they're taking. We know people are discharged with, many older adults are going to have many more medications, and if they can't tell you what those medications are and you don't have access to that information, it's really difficult. I always think about a patient of mine that I had who was an older adult with stage 4 colon cancer who was getting chemotherapy. He knew he was due for another round of chemotherapy, and that was about all he could tell me. So, it looks like this in the clinic. You say, okay, you have stage 4 cancer. I don't have access to your records. So where did you go for your treatment, right? And so this particular gentleman was at CMC, which is a prison in San Luis Obispo. So I said, well, when you got in the van to go to your oncologist, was the ocean on your right or on your left? It was on the right. So I know he's heading south. Well, how long were you in the van for? Was it 10 minutes or was it more like 30 minutes? Well, it was more like 30 minutes. So that's probably Santa Maria, because that's the next biggest town. Do you know your oncologist's name? Well, I think it starts with the letter M. So I'm Googling Dr. M, Santa Maria oncology, and miraculously find this person's oncologist and get some records so that we can try to continue the thread of his care. So I think that's incredibly challenging. The more complex your patients are, and it becomes more critical to have access to those health records. And also for the patients to have an adequate supply of medications. From our work in the Transitions Clinic Network, kind of the average amount of time from incarceration to making it into our clinic is actually 4 weeks. And so if people are getting a 4-week supply or a 30-day supply of medications, it's really not enough for most people to safely get them into primary care. As you all know, people have to address all their social determinants of health at the same time when they come out, like housing, employment, and transportation. This is particularly challenging for older adults for a myriad of reasons. I think one thing that's also really important to realize is that when people come out of incarceration, they have more barriers to meeting their basic needs. So these are called collateral consequences of incarceration. As I'm sure many of you are aware, there's 40,000 of them nationwide. So these are documented laws and policies that continue to punish people post-incarceration. And the large majority of them are centered around employment, but can also impact housing, in some states, SNAP benefits, voting, et cetera. And so it's really challenging for people. And if they have low literacy levels, and particularly in older adults, cognitive impairment or poor technology skills, it's really difficult for people to navigate these systems on their own. I think also some of the challenges, housing is a big issue for our patients coming out. And I talked a little bit about the housing challenges. In our state, in California, parole is giving housing, temporary housing, to most people returning from incarceration, but they may not, the housing services may not be patient-centered. And the gentleman I was telling you about who, went to the emergency department over and over was staying at a halfway house that, really didn't have ADA supportive rooms, and also did not have kind of that additional caregiver support that this person needed to function in the community. And he really needed somebody to help him take his medications and to kind of be with him much more closely. And when we look at housing in the community, it's not just housing, it has to be the right kind of housing for our older adults, either assisted living, adult foster homes, or more informal care for patients who might have family members or friends who can care for them. And I think it's important to recognize that sometimes the parole and probation policies really exclude family supports that people may have. So, as we know, social isolation is a big issue for people coming out of incarceration. The older you are, the more disconnected you may be from family. Many of our patients, their family is no longer alive because they've outlived many of them. And so they may not have family support, but for people who do have family support, sometimes parole and probation policies exclude people from living with their families. They can't return to their county of commitment where they committed their crime. And there's usually not exceptions for older adults to be able to go home and get the supports they need. So there's a lot of barriers to getting appropriate support in the community around housing. And then lastly, people who are coming out of incarceration experience discrimination, and they have a high distrust of health systems for good reason. Our patients are, communities of color who have experienced discrimination at the hands of the health system. And for people with incarceration histories, there's documentation that they do experience discrimination because of their criminal records in primary care. And so there was a study done in Canada that showed that when people identify themselves as being recently released from prison, they're less likely to get primary care appointments. So tremendous barriers for people in trying to engage into care. This is just a quick slide on the 44,000 collateral consequences of convictions. You can see mostly the largest number is employment, which can be really challenging to get a job. And then if you're an older adult and you don't have technology skills, the jobs that are available to you are really kind of physically based jobs. So it becomes really difficult for our older adult patients to get jobs. So I'm going to kind of shift gears a little bit here and talk more about our work in the Transitions Clinic Network and our model of care, and really kind of looking to change how we do things in the health system. I think that study by Ingrid Binswanger showing that people are 12 times more likely to die really points to health reasons as the reasons people die, and that the health system plays a really important role in supporting people in that transition home. So we want to, I think we really want to move away from that punitive model. We want people to build trust with the health system. And then we really also need to move away just from addressing medical need, but also kind of really looking at the individual more broadly in our health systems and addressing all of their behavioral health and social determinants of health. So in order to do this, actually, Emily Wong and Clemens Hong started this process back in 2006 in San Francisco, where they convened a group of stakeholders in our community to really better understand what were the needs of communities returning from incarceration, and how do we engage people in care, and how do we transform our systems. And so the community said, well, number one, you have to include people who are impacted by incarceration in the design, implementation, and evaluation of all of your programs if you want them to use them, right? And it seems so basic, right? It's this, they're the end user, they're the consumer, whatever you want to call people who are using our systems, but because people are incarcerated and lose their autonomy, right? They're given a number instead of a name. They're just they've really lost any agency in the system. They're so infrequently not included in any policy discussions or planning around what the needs may be for people and what will work to support people. They also said you have to incorporate a broad definition of health and well-being. So as I talked about, people's health needs are not just their physical health needs, but go way beyond that. And that you have to adapt your systems to meet their needs and not expect people to be able to adapt to your systems. You have to empower patients and favor reintegration. So I think this is also a really important piece in that our work are programs that are embedded within existing primary care clinics. We're not setting up new clinics that are separate for people coming out of incarceration. Instead, the idea is we're integrating people into the same community health systems that their family members are using, and they're being treated like anyone else in the community. So they're sitting in our waiting rooms just like anyone else who's seeking services in the community. And then also very importantly to our community is that we need to avoid replication of correctional systems or punitive systems. So one, they want to know when they see their doctor and they're in that room, it's totally confidential, it's wholly apart from the carceral system, and that we're not inadvertently replicating those punitive systems. So that's how the model of care got developed, and that's how the Transitions Clinic program was started. It's a model of enhanced primary care. So again, as I mentioned, it's centered in the primary care setting. And what's unique is that the primary care clinics hire community health workers with lived experience of incarceration. These are individuals with felony convictions who, are seen as untouchable by the health system. Because our patients are vulnerable, health systems traditionally don't hire people who have felony convictions. And a lot of our work is transforming HR systems and working with clinics to understand the value of that lived experience and to hire community health workers with lived experience of incarceration and to embed them within primary care teams. Also part of those teams are mental health providers. We provide substance use treatment. specialty care, like things like, hepatitis C treatment for our patients. We do trauma-informed care and support people related to trauma. And then also our clinics all have community advisory boards that are primarily made up of people with lived experience who can continually inform the work. And so the clinics transform not just what they're doing inside and who their teams are, but how they relate across systems with other providers. Most importantly, the criminal legal system and the system of community supervision, as well as the reentry system, so community-based organizations and other kind of networks of community supports like faith-based supports or family supports, and then other aspects of the health system like the behavioral health system, the hospital system, and also housing. So the community health workers are really kind of what we call the secret sauce. They're always constantly informing what we do. And they're the ones that are, really interfacing with the patients. And what's unique in some ways about them is that unlike other staff in the clinic, they're half time in the community and half time in the clinic. So they are doing a lot of outreach and engagement. This is why the patients come, because of the community health workers. This is Ron Sanders, one of our workers, meeting a patient who's in the hospital and engaging him into care. The community health workers go everywhere into the community, homeless encampments, any residential drug treatment programs, probation, parole, anywhere you might find someone who's recently released from incarceration. And this is actually the number one way we get patients into clinic, not the in-reach, which we do, and it's variable across sites, but it's really the outreach in the community that is the most effective in getting people in. We do get to do some in-reach into prisons and jails. This is highly variable depending on the leadership and the entities that we work with, but sometimes we'll do fairs or we'll do, one of our sites in Richmond, California does an incredible support group in their jail to engage patients. So we see a lot of different variations on how this can be done. And there'll be I'll talk more about increased opportunities for doing this moving forward. The community health workers provide health system navigation. This is so key for our older adult patients for the reasons I already outlined. This is Ron in the waiting room meeting patients. We've had patients who come into the waiting room and they didn't know that they were supposed to check in at the front desk because they've been incarcerated for so long. And you get a docket when you're inside and someone tells you where to go and what to do. So we've had people come into our waiting room and just sit there and stay there all day or all morning until we realize that they haven't checked in it, but they are in the waiting room. So now we station our community health workers. They're in the waiting room to welcome people and help them usher through our clinic and also support them in all health system navigation. Here's Ron with Emily seeing a patient. The community health workers also play a really important role in cultural interpretation and really kind of helping that patient communicate with the provider communicate with the patient, really, helping us as providers understand whether our treatment plans make sense for the patients. Sometimes we think we have great ideas, but we don't really understand the needs of the patient and what's happening with them. And so the community health workers are a really important piece in working together with the patients to meet their needs. The community health workers also help with the self-management support. And I talked about why this is so critical because people may not have these skills. They may be dependent on systems. So they work closely with them and help them learn what are their medications and how to go to the pharmacy to get them refilled. And then the social service navigation, all of the social determinants of health, housing, employment, all those kinds of things. Here's a patient of ours who's elderly and homeless. This is Ron bringing him some food from the food pantry that we have in the clinic. And then the technology coaching. This is just one example of ways that we try to support people in their transition and reintegration into the community. Here is a patient kind of getting some tech support. With some of our older adults, some of it is just the basics, like how do you answer your phone and how do you check for a voicemail? Because if I refer you to radiology, they're going to call, and if they don't get you on the phone, they're not going to make that appointment. So those basics, I think that I have an 80-year-old patient I care for. He still writes me letters, even though he's just a mile or two away from our clinic, I still get handwritten letters from him when he has a question or problem, because that's what he's comfortable doing. So the technology coaching, is highly variable depending on the kind of interest and abilities of the patients, but is so key. And just even the things like learning how to use the telephone. And then that emotional support and mentorship is really key. Here's Ron with a patient. I mean, the social isolation in our older patients is tremendous. People often have no one when they come out of incarceration for such a long period of time, or if they do, they've lost track of those family members. I think about one of our other older adults who had pretty significant cognitive impairment, who our community health worker was able to get on Facebook and track down some of his family so that he could go stay with them. So, this is a really important piece of having the community health workers. And I think the patients also really look up to the community health workers and see that here's someone who transitioned successfully from incarceration. And if they can do it, then I can do it too. And then lastly, the community advocacy piece is critical. When we see policies or issues within access to care or services, we are able to advocate for change. And the community health workers are trained in community advocacy so that we can continue to try to change the systems that we work in. So here's some data from our program. This is from CMMI, as you heard. We did get a CMMI award. And this is, just showing kind of the mean age is 46. And we do care for a lot of older adults, primarily male, primarily people of color who are single, so may not have a lot of family support, don't have high levels of education, and have very low rates of stable housing. And very high rates of chronic health conditions. So 43% of people, 3 or more chronic health conditions, along with substance use disorders. So again, these are fairly complex individuals who are older with multiple chronic medical conditions, and have a high need for social determinants of health. This is similar. This is from the same data from our CMMI prospective cohort study that you can kind of get a sense of what were some of the needs of our patients around the social determinants of health. Housing is really kind of the #1 piece that we work with patients, and they also get support with things like medication management, care coordination, physical health, and behavioral health, as you can see. And then a lot of, emotional support and check-ins, a lot of texting and just kind of checking in to see how people are doing. So our program has been shown to improve health outcomes. This is a randomized controlled trial that was led by Emily Wong in San Francisco that looked at 200 people who were coming out of incarceration to San Francisco, and the community health workers engaged people to come to our program at Southeast Health Center. And then they were randomized to either stay with us or to get regular care in our system at other primary care clinics. And people in our program were found to have 50% fewer emergency department visits in the first 12 months post-incarceration. Another study is also from this CMMI prospective cohort study, where we looked at 751 patients across our sites nationally and found that when people were referred from the criminal justice system, they actually had an association with decreased acute care utilization, and also that if they had food security, they were associated with having a decreased acute care utilization. And so kind of as a result of this, sort of showing that there's an importance of starting earlier and having those relationships, although they are very difficult to develop. And then also that food security piece, or the social determinants of health, can be associated with improved health outcomes. And most of our sites do have food pantries or support patients in getting access to food. And then the last study I'll share is this propensity match study. Again, Emily Wong is the lead on this study. This came out of data in Connecticut, where she linked the data from the Department of Corrections, Medicaid data, state Medicaid data, the Department of Public Health, Department of Mental Health in addiction services and court services, to then look at comparing TCM patients who were coming to New Haven with a propensity match control who were released to a different city in Connecticut to Hartford. And this study really was looking at both health outcomes and criminal justice outcomes. What's not on this slide is that it did show a reduction in preventable hospitalizations for TCN patients. And here this shows that TCN patients had fewer probation and parole violations as compared to their match controls in Hartford. And as a result, spent 25 days fewer in jail in the first 12 months post-incarceration. So I think this study is really profound in the sense on two fronts. One, of course, it's great to see that investments in Medicaid can also not just have impacts on health outcomes, but also on the criminal legal outcomes. And also, I think this is a unique study in this kind of these linkages across systems between the carceral system and the health system, which are very difficult to do, and few states have those mechanisms set up, and it can be really challenging, but is going to be really important as we move forward with a lot of the new policies that are coming down the line, which we'll talk about at the end of this presentation. So COVID really exposed these gaps in care coordination, right? So in our state in California, they released many people early to try to mitigate the spread of COVID across the carceral system. Clinics were closed, everything was shut down, and it really exposed these challenges in the care coordination piece. And our response in California was to try to shore up those linkages between the carceral system and the community health system. So we created what we call the healthcare hub that consisted of both a hotline that people could call who were incarcerated or recently released, and an online referral platform that linked the state prisons, all 35 state prisons, to our network sites in California. And in California, we have 21 federally qualified health systems that are caring for people returning from incarceration. And so they kind of all got together during COVID to create a network that made it easy for state prison to make these referrals. And we hired some staff that really managed this, where we could get electronic referrals so we would know who's coming out, when they're coming out, what their chronic medical conditions were. We could share medical records and make appointments. So I'm going to kind of fly through this just kind of for the interest of time, but we did this for over 5,000 people. And I think what's kind of most interesting here, though, is like this is an administrative linkage, right? It's linking one system with another. But people were, during COVID, you couldn't really connect with those individuals. Things were shut down. They weren't running clinics. So it was very hard for us to make a connection with the person inside before they were released to the community. So a lot of those supports were administrative. And this is problematic. And this data kind of shows why. This is programmatic data from one of our sites in California, in Santa Clara, where in their jail system, they were making appointments for people leaving jail who had chronic medical conditions, and only 33% of those people would show. So when you do this kind of administrative linkage, you're really only going to get about a third of people using that appointment. But when they had their community health workers with lived experience of incarceration go into the jail, the show rates went up to 70%. So when we think about what we were doing in California of making these linkage, it's critical because now we're creating a linkage across systems, and yet we're not going to always get the intended outcome we want unless we're able to connect with people pre-release. And so part of our way of mitigating that was the community health workers decided to all come together. These are some of the community health workers from our 21 sites in California to create a hotline. And this is where the community health workers said that we know what to do. We know how to get a hold of people during this time. And they designed this health hotline, implemented it, and were involved in thinking about ways to evaluate it. And so we had over 1,200 hotline calls. And what was interesting was that many of the calls were actually, the large majority, 66%, were from people who were already released from the community. So that's when people really start thinking about when they have challenges and when they're going to need these linkages. So that was kind of a really interesting piece for us. But just even thinking about, okay, great, well, we want to have this hotline, but how do we get the word out? Well, the community health workers know people who are inside. They write letters to people all the time. They know that there's a newspaper that comes out of San Quentin that goes across to the entire system. And that word of mouth is so powerful. And so having the community health workers and designing this and knowing what should be the hours of the hotline and how this should function was really kind of a big component of its successful implementation. So I'm going to kind of, thank you. Sarah is just reminding me of time, which I really appreciate. So, I think just to kind of wrap up here, I just want to share that's kind of the bulk of the work we're doing. And we're really looking forward to a major policy opportunity that I think is going to have a significant impact on older adults, which is this potential of waiving the Medicaid inmate exclusion. So, with the Support Act, the Medicaid Reentry Act, there's a real push to what if we actually remove this exclusion for 30, 90 days pre-release, and we're able to connect with people and do care coordination and get them safely from prison to community health systems. So this is something that CMS supports, that there was a listening session and they're going to have recommendations around best practices. States are already applying for 1115 waivers. These are policy shifts within states that would allow them to use Medicaid dollars to do something like this. In addition to waiving the Medicaid inmate exclusion, there's an increased focus on using Medicaid dollars for looking at things like enhanced care management. So these are specialized services or like team-based care, similar to what we do in the community, and also addressing the social determinants of health. So kind of moving forward, I think we're going to see a real opportunity to create better systems of care across carceral systems and health systems. And I'm hoping like more opportunities to also learn about these challenges people face, to evaluate and really engage in research around this. So I think it's going to do a quick time check. We have about 10 minutes. So maybe I'll take some questions if anyone has any. And then I don't think we have time to do any sort of breakout groups, but I would love just to hear people's reaction to this presentation, what your thoughts are, around where you see some of the biggest gaps in research around providing reentry supports for older adults.
Maybe I'll start just because I will, if that's okay, Jen. And then, please feel free to raise your hand and ask a question. But I would love to see a study, if you haven't already done it, and God knows you all have done so much research, you maybe have already done it, but I would love to see a study by community health workers who talk about the strategies that they use when somebody has cognitive impairment, and thinking about, how really it would be a paper for clinicians to help us understand what we can do best and better to help with the transitional care of this population. So that's just a paper I would love to see. And if you have already written it, let me know what it is.
No, I haven't, but I love that idea. I'm curious, like, if anyone has written anything like that in other settings of older adults that you're aware of.
I'm not sure that I'm aware of anything, but Jelaine might know, and we have a bunch of, maybe Lisa Berry knows, we have a bunch of cognitive impairment kind of experts on here, but I don't know that there are as many people using an integrated system of community health workers where it's really beyond one clinic. And so the idea that you could learn from people really throughout the nation in different scenarios, who may all have different types of strategies and suggestions for clinicians, would be like, I just think it would be mind-blowing.
The only thing that jumps to mind, Bree, is the care ecosystem that was launched in the MAC that Kate Poseen runs, where they have care navigator partners set up in both, I think, mostly rural environments to help. But I think they're mostly engaging with family members about how to sort of negotiate and, oh, thank you. Yes, the Memory and Aging Center, for those who are unfamiliar at UCSF, is the MAC. But they have care navigators who are partnering with families and stuff like that. So that would be a potential option there.
It's really helpful. Yeah, I think that's a really amazing idea. And I think the other thing I would love to, I think is so needed, and I think would need to be sort of researched as well, as just like, how do you evaluate people's cognitive impairment and kind of their ability to manage their IADLs from the incarcerated setting before they're released. I think for us, one of the big boons of having this online referral system was that we then could flag people who potentially had cognitive impairment before they were released. So we could, like, when we see something that kind of seems like, oh, this could be problematic, we jump on it and we try to get involved early on. But we don't have any really validated tools or good ways to really assess that pre-release. And so, I think even in conversations with our state around our policies that we're developing related to the care coordination and removing the Medicaid inmate exclusion piece, they're asking, like, what tools should we be requiring that correctional systems use to assess people prior to release? So I think there's a major opportunity. And yet I wasn't sure, like I couldn't point to, oh, here's this validated tool, or this is what should be used. So I think there's a real opportunity there.
We're getting oh, go ahead, Laura.
I was just going to say, in our elder reentry initiative that we've been doing for a little over 7 years now, we have an assessment that we use that so far as works for us pretty well, but it's never been validated or anything like that. But it seems to work, and we also use the MOCA and the mini-cog in terms of assessing cognitive, doing a cognitive assessment, but in terms of assessing their ability to, like, grocery shop. We have a variety of other things that we use, but it's long. It wouldn't be something, it's something that we can do because we spend quite a bit of time with folks, but it's not something that most other people would be able to do, I think. Yeah.
That's really interesting. I'd love to learn more about that, but I wonder also, Laura, do you think it could be condensed to something that others could use?
Yeah, I mean, maybe. I mean, we do things like we look at their disciplinary history, like, are they getting a lot of out of place tickets and other things? So we kind of look at documentation also. So I think we'd have to look outside of our system to kind of look at other systems to think about, like, what could each system look at to kind of get the view that we do of each person, to bring together the same evidence that we do in order to get that kind of a picture of a person.
Yeah. There's a question, Laura, about where you're working.
Oh, I'm sorry, in New York State.
In the state prison systems.
In the state prison system, but also at Rikers.
Mm-hmm. I mean, that makes a lot of sense, like using this sort of other data too. I mean, I think because it is hard to really paint that picture. That's really smart.
Mm-hmm.
There are a couple questions in the chat. Yeah.
Thank you. Yeah, go ahead.
Well, yeah, I'll just read. So from Ben, do you think that further research into post-incarceration utilization and cost is needed to strengthen the fiscal case for more robust reentry services?
I do think it would be helpful. I think that's a good question. I mean, I think, that's a broad question. I think it depends on really specifically what we're getting at, because I think there's an opportunity with removing the Medicaid exclusion piece to look at cost. I think that needs to be well evaluated. I'm just trying to think, like, in my experience, if the cost argument has really made a huge difference. And, I think part of the challenge is, like, when people come out of incarceration, they're using more services. So that actually is not, necessarily cost saving. So it's a little bit of a complicated situation, but I do think it is important. I mean, I think in our data, what's been really interesting is that where we save the most cost is actually on the criminal legal side, people spend 25 days less reincarcerated, and that's probably the most cost savings that we see. And so then there's this kind of conversation of, well, you're spending money in one bucket and saving in another. And I think sometimes that's, depends who you're talking to, whether, they're just focused on their bucket or kind of looking across systems. So I would think, yes, I think having more data is important.
And then there was a couple questions about requiring long-term care. If you could estimate what proportion of people would need long-term care. And I know this has been a really big issue with compassionate release, and nobody wants to take people into long-term care, and payment for long-term care is quite complicated. So yeah.
And so how do you estimate the need for long-term care? I think this is where, it really is sort of reliant on the correctional system. So in California, that because we're under federal receivership, we've been required to do a lot more tracking around people's health, their utilization, where they're housed. But what we see is it doesn't always translate to what sort of their level of care would be in the community. And they oftentimes try to kind of downplay people's needs when they release them. So I think, having access to those data maybe would be helpful in trying to project from our state, what those needs could look like. But I think, I don't know if they would give you that access to that information. So I think it is challenging. And I don't think that what's called like a sniff inside doesn't always translate to what that is in the community. And I think with certain supports, people could probably function more in the community. I'll give you an example. I have a patient with a tracheostomy who was in a skilled nursing facility and then there's respiratory therapy there. So like every week they're coming and changing his trach. And it's actually something that people, that's not necessarily supported in the community, but he got very dependent on that. So I think it doesn't always translate across. So I think there's some challenges there, but maybe in broad strokes, if you could get access to the data of what's being done inside, you could estimate.
Wow, it seems like it's like the constant theme is that conditions inside and needs inside are not at all reflective of what needs are on outside, and then like really speaks to a need to redesign prisons to be built to transition back to community, right? Like,
yeah, absolutely. And I think also just like the categories that exist in the prison system, like are not directly translatable to the community, even around risk. Like I think we found this in doing the propensity match study that initially when we were trying to do the match, the risk level of chronic conditions that the prison set up just didn't even make sense for in the community. And so you can't sort of assume that the categories of risk or even housing within those systems translates to what we know in the community.
Well, I know we have to wrap up. I think I get in trouble with Sarah if I don't make sure we have a stretch break. The last just quick question I just saw that I thought just plug in is if any of the TCN network clinics work with area agencies on aging. So I don't know if you know if anyone does that. Someone had a question.
I don't know the answer to that, but it's a good question.
It's definitely a resource that they could use. I was actually thinking the same thing. It wasn't for me, but it's a great question.
Well, thank you so much, everyone. I hope let's give another virtual or whatever form of round of applause to Dr. Shavit for sharing with us. And Shira, I hope if folks have ideas and want to work with you and can reach out with additional research questions, I'm hoping you'd be amenable to that. It's also
absolutely. Thank you all so much. I really appreciate it. And yeah, please don't hesitate to reach out. I think I saw it, like someone did reach out in the chat. If you can, I'm going to put my email in because I know these chats are going to go away. So just write to me directly. That would be really helpful. So thanks, everyone.
Except it's Shavit.
Oh, thank you.
I'm positive that's how you spell your name.
I misspelled my own name.
I keep signing my emails BRE, so it's a big disaster too. But anyway, it's something about that I, Shira. We just can't get it. Thank you so much, Shira. We are so thankful. Thank you, Jen, for moderating.